Well, it's a great pleasure to introduce Karine Lacombe. Is an infectious diseases specialist, head of the Infectious and Tropical Diseases Department of the Hospital Saint-Antoine in Paris. It's a member of the EACS guidelines panel, a peer reviewer of many high-impact journals in this area. She has a huge experience in France and also in Saharan Africa on HIV and viral hepatitis co-infections. Has a lot of publications on natural history and therapy on HBV co-infection. That is the main theme today. So, professeur Lacombe, c'est un plaisir. Merci d'être avec nous et d'avoir accepté l'invitation de Resida, comme vous voulez.
Merci beaucoup, je suis très touchée. Thank you, I'm very happy to be here today to talk about the contemporary issues in HIV/HBV co-infection. And it's going to be a kind of provocative talk because I started last year when I went to Madrid to talk about the co-infection issues, and I've raised some challenges, and the colleagues in the room were not very happy with, not happy, but they did not argue about what I wanted to say regarding some simplification of the treatment, etc. So I'm going to raise that issues today with more data. So first of all, I'd like to give you an update on global prevalence of HIV/HBV co-infection, and that's a very new paper that has just been released in Journal of Viral Hepatitis. Unfortunately, you won't find it on the website because I think that there is some issues regarding the authorship, but at least there is an abstract, and I think it's very important to have those data in mind when talking about contemporary issues of co-infection, because when we see the numbers, it really looks like we have not finished with hepatitis B, unlike hepatitis C. So that's a meta-analysis done from papers published between 2002 and 2016. It's been conducted by WHO to inform the last guidelines on hepatitis B and HIV released in 2017. So they did the meta-analysis based on 506 estimates of HBS, sorry, that's a typo error, HBS antigen prevalence from 41% of countries around the world. So it's not majority of the countries around the world, but that the countries where we had estimates of hepatitis B prevalence. And you see that's the most updated prevalence of HBsAg in HIV. Patients at 6.1%, which means about 2.6 million of people living with HIV being also infected with hepatitis B. And that's no surprise to see that the greatest burden is in Africa with 69% of the cases, and the prevalence is higher in people who use drugs, almost 12%. And on top of that, in this meta-analysis, they have found that the prevalence of hepatitis B is 1.4 higher in people living with HIV compared to HIV negative individuals. So where does that bring us when we look at the major issues in 2020 regarding HIV/HBV co-infection? So I've looked at what we can transfer from the HIV field and HBV field, from the monoinfection to co-infection, and I've identified 4 issues that I would like to share with you today. 2 from the hepatitis B field, novel diagnostic markers and the novel therapeutics, and 2 from the HIV field, the treatment simplification and the new drug classes, and where do we stand with the new drugs in HIV/HBV co-infection. So first of all, the novel diagnostic markers. You know the issue with the current HBV marker that we are using, HBV DNA, HBe antigen quantification, HBs antigen quantification. You know that those markers are not very good markers to look at functional cure in hepatitis B, because when we use treatment, we have exactly what we see here in that picture. There is a decrease in HBV DNA, so a complete HBV DNA suppression, but HBsAg is persisting all over time, and that's why we can't talk about cure in HIV/HBV patients, even if HBV DNA is going down and ALT is going down as well. Quantification of HBs antigen is still up. And even when HBV DNA is completely controlled, there is still the risk of hepatocarcinoma, and you see that from the picture on the left, on the right of the slide. So on top, that's the patients with no cirrhosis, and at the bottom, patients with compensated cirrhosis. And if you look at the patient with no cirrhosis, even if HBV DNA is controlled, there is still a risk. Low risk, but still a risk of developing HCC. So why that? It's because there is a persistence of HBsAg in the liver, which is oncogenic. You know that we are in a period where we are talking about HBV cure, because a lot of new treatments are being designed which targets different cycle targets in the viral cycle of hepatitis B. That's why we are looking for new markers that would really reflect what is happening in the liver when we talk about when we target functional cure. So you see on this slide that there is a liver, and here that's the hepatocyte, and here that's the blood, and we're looking for novel markers that will reflect what's happening in the liver, and here marker that can be found in the blood, because it's very difficult to look at markers in the liver because, you know, the biopsies, etc., that cannot be done anymore on a large scale. So what have already been shown in hepatitis B monoinfection, HBV RNA, for example, it's a good surrogate marker of the efficacy of nucleosides discontinuation and HBeAg cellular clearance. Quantification of HBCR antigen can help to differentiate states in natural history of hepatitis B. It can also help to monitor nucleosides discontinuation. It can help to have a good prognosis of HBeAg cellular clearance, and it can be a good marker of the occurrence of hepatocellular carcinoma. Quantification of HBeAg obviously is associated with cellular clearance, so it's a prognostic factor of cellular clearance, and HBsAg quantification is also a prognostic factor of HBsAg cellular clearance. And this one, anti-HBC antibodies, it's gaining a lot of importance to be as a good markers of immune response towards hepatitis B and HBeAg cellular clearance. So, could these markers be helpful in HIV/HBV co-infection? Here again, in the paradigm of functional cure in hepatitis B. So in the French HIV/HBV cohort, we have looked at those markers as markers of clinical issues, such as AIDS-defining illness or the level of CD4 cells, and we have shown that in a paper which is being submitted right now, we have shown that there is definitely a significant association between the quantification of HBCR antigen with AIDS-defining illness. And there is an inverse correlation between AIDS-defining illness with quantification of anti-HBC antibodies, which is not a surprise because anti-HBC antibodies is increased when there is an increase in in the immune system. The same for CD4 cells, not associated with HBCR antigen, but associated with quantification of anti-HBC antibodies, and that's a positive correlation. Now, regarding HBeAg antigen, people with wild strain of hepatitis B, we have already published some data regarding the prognostic factor of HBe antigen quantification in predicting HBeAg cellular clearance. And you've got here the results, and we have looked at the new markers, anti-HBC antibodies and HBCCR antigen, and you see that the prognostic value of those two new markers are not better than HBeAg quantification. And that's here some of the results on a graphic way. So you see that the kinetics of HBCR antigen in HBeAg positive is significantly decreasing under TDF treatment, which is not the case in HBeAg negative patients. And you see that in patients who have lost HBsAg, it's a very good marker of loss of HBsAg, the decrease of HBCR antigen. And regarding now the kinetics of this immune-related marker, which is anti-HBC antibody, again in the same French HIV-HBV cohort, you see that the kinetics is not very good in HBe positive, HBe negative, or in patients who has lost HBsAg. So the remaining questions regarding the use of those new markers in HIV-HBV co-infections are quite a number, and I think that they are unanswered so far. The markers here, HBV RNA, pregenomic RNA, the other circulating RNAs, and the quantification of HBsAg as novel diagnostic markers in the perspective of functional cure and use of the new drugs for hepatitis B cure is not answered, and it has to be assessed in big cohorts in order to have the significance and see if we can use those markers as surrogate markers of functional cure in HIV-HBV co-infection with the new HBV drugs. And there are a few studies going on, especially with EuroSIDA, the Swiss HIV cohort, and our HIV-HBV cohort. And again, there is obviously a huge field to investigate regarding the use of those biological markers in predicting the issues and the liver damage after being HBV controlled, especially here with hepatocarcinoma. And those markers, the use of those markers will be assessed in EuroSIDA and the Swiss HIV cohort, because we have the good number of HIV-HBV co-infected patients in these big cohorts. The second issues around HBV monoinfection that can be translated to HIV-HBV co-infection is the issues of novel therapeutics. So the rationale from the HIV context, why do we need new HBV drugs to treat HBV and HIV-HBV co-infected patients? And that's an illustration from the co-infection. This paper has been published a few years ago, but that's one of the landmark papers showing that the treatment of hepatitis B in co-infected patients works very well with almost 100% of HBV DNA suppression, even if there is still here about 5% of patients who are not controlled despite long-term exposure to tenofovir. And why that? Why can't we cure HIV-HBV co-infected patients from hepatitis B? Well, we've performed a study in the French HIV-HBV cohort where we have looked at the markers like quantification of HBs antigen in the blood, but also the correlation into the hepatocytes, looking at intrahepatocyte DNA and also CCC DNA. And what we have shown here, that there is first no decrease in quantification of HBs antigen despite treatment, long-term treatment. You see 108 months here. And in the liver, the results, although there is a decrease in CCC DNA and total intrahepatocyte DNA, there is there is still some CCC DNA at 60 months of treatment, and that is due to the replenishment of CCC DNA pool from the infected hepatocytes despite the viral suppression. And this is in the same cohort at the same time. You see that after 8 years of tenofovir, we reach almost 100%, but in the same cohort, you see that HBsAg is quite stable and with a decrease in CCC DNA, but no disappearance. That's why in HBV monoinfection, there is a huge research regarding new drugs, and you have probably seen that kind of picture. This review here from Fanning, just published, is a very good review of all the new drugs targeting the viral cycle. So that's here the hepatocyte and the viral cycles, and all those squares here mention the new drugs against hepatitis B cycle. And here, for example, the entry inhibitors with Myrcludex, here the capsid inhibitors, here the NAPs, so all those drugs look very promising in the future. So that's in the viral cycle. And here, that's all the drugs targeting the immune system. And I will not go deeply into that, but you see that the field of HBV cure is very broad. So how, if we look at the drugs, the DIA, so it's not in hepatitis C, it's really in hepatitis B, but that's also direct acting agents, antiviral agents. I've listed here a few of them, the more advanced, like the drugs, the capsid inhibitors from Janssen and the TLR 7 and 8 from Gilead and etc. And the drugs from Roche, especially anti-PD-1, which are on trials for HBV monoinfection. And that's really the problem with co-infection. So far, there is absolutely nothing regarding the evaluation of efficacy of those drugs in the context of HIV-HBV co-infection. For example, there is so far no known studies regarding the drug-drug interactions with antiretrovirals. Maybe it's too early, but still, some of those drugs are already hitting phase 2, and even phase 3 studies. So why there are no drug-drug interaction studies? We're going to be very far behind if we do not invest this field of research. And regarding the trials for HIV-HBV co-infected patients, there is no trials in this specific population, at least not yet. If you look at clinicaltrials.gov, there is no registered trials, but I know that some groups, like the SATG network in the US, is bringing considerable interest in that kind of trials, and I think that us in Europe should not be behind. Now, the third issue is the treatment simplification. So you all know that in the HIV infection, it's a big field. It's been a big field of research for the past 3, 4, 5 years, and now dolutegravir lamivudine has been proved to be non-inferior to a 3-drug regimen with respect to suppress HIV RNA. And if we look at the recommendation, like EAC's recommendation, and in parallel, EASL recommendation, the preferred regimens for HBV monoinfection is TDF, TAF, and entecavir, and lamivudine, adefovir, talbivudine cannot be recommended for the treatment of chronic hepatitis B. And that's why in EACS, now that EACS has integrated 3TC dolutegravir as a drug that can be used to initiate treatment in naive patients, it's not recommended, it's even contraindicated to apply this 2D strategy to patients with hepatitis B infection. And there is also, for switch, an alternative regimen, which is dolutegravir and rilpivirine. So all our patients with hepatitis B infection cannot be eligible for a 2D strategy. So why that? First, because lamivudine is considered as a drug with a low genetic barrier, so we are really fearing for our patients to evade the treatment and then have a flare in hepatitis B, DNA, and transaminases. So what does that come from? It comes from all studies done, you see here, 1999, 2006, where the patients treated with lamivudine at a time where we did not have tenofovir were highly viremic. If you look at really the characteristics of the population, including those trials, 2/3 of them were HBeAg positive, and most of them had a sexual transmission route. And here you see that the percentage of resistance after 4 years of exposure to lamivudine was very high. That's why we said that lamivudine was not a good drug for HIV-HBV co-infection. But if we go back, if we go further and look at the patients we have now, For example, in this study we did in Côte d'Ivoire, where we have been able to compare lamivudine on one side from the patients included in an interruption trial called Trivacon, where the patients were exposed to lamivudine, and in another trial called Temprano, where the patients were exposed to tenofovir. We did an exposure study, and we compared the patients with lamivudine and tenofovir. Those patients had low viremia when they were included in the trial. 1/4 of them only were HBeAg positive. All the others were HBeAg negative. Most of them were considered like inactive carriers for hepatitis B. In patients who had a viral load less than 100,000 units, we saw no emergence of LAM resistance after 36 months of exposure to lamivudine. And you see that about 75% of them reach undetectability at 36 months of exposure to lamivudine, and it was about 85% with tenofovir. And we had only 2 cases of LAM resistance in patients with high-level persistent viremia. So in that kind of patients with HBe negative, low HBV DNA at treatment introduction, there is a low risk of LAM resistance. That's why we have to reconsider our position regarding the use of a 2D strategy in HIV-HBV co-infection in very specific patients. Second, the second side of treatment simplification is very simply stopping hepatitis B treatment. So we have data from HBV monoinfection. Here, the FINI trial, which has been published just that year, and that's HBV monoinfected patients, 44 patients who have been randomized in tenofovir stop or tenofovir continuation. And you see here the main result, 13 out of 21 did not restart tenofovir, 4 lost HBsAg, 3 acquired anti-HBs antibodies versus none in the group of patients who did not stop tenofovir. All the patients in the group who stopped tenofovir had a rebound in HBV DNA, but after the rebound, most of them controlled replication without restarting treatment. And if we look at the immune data under stopping TDF treatment in HBV monoinfection, we see that there is a restoration of functional T cell after tenofovir interruption. And you see that here the HBV specific CD4 T cells, which are higher after 12 weeks of treatment interruption, the same for CD8 T cells. So the remaining questions for HIV-HBV co-infection are of 2 kinds. Can treatment simplification work in that populations and where HBV DNA replication is controlled? So we have to define which patient could be eligible to this simplification strategy. Complete HBV treatment interruption by switching to dolutegravir ripivirine, for example, or partial HBV treatment simplification by switching to dolutegravir 3TC. So I think that's really a question that needs to get an answer in the present context of the 2D strategies. And finally, the new drug class, integrase inhibitors. You know that most of the patients, either in switch, but more even in treatment initiation or started with anti-integrase. And there is a question that still remains regarding the impact of INSTI on seroconversion of HIV-HBV co-infected patient, which means lose of HBe antigen and lose of HBs antigen. And this question has arisen from the analysis of the patients included in a cohort that have switched to elvitegravir, cobicistat, FTC, and TAF, 72 HIV/HBV patients. That has been published some time ago. And here you see the patients historically on TDF-containing ART. The seroconversion, HBeAg seroconversion, has been estimated to be 2 to 3% per year. And in this study here with elvitegravir, you see that the rate of seroconversion of HBeAg is 3.3% after 6 months of treatment. And when we look here at the HBsAg seroconversion, less than 1% per year under tenofovir, and here 2.9% at week 48 under elvitegravir and TAF. And in this case, which has been reported very recently, talking about immune reconstitution syndrome in patients treated with INSTI, and in that case it was raltegravir, they have shown that the patient put on raltegravir has very quickly seroconverted, lost HBeAg, and got a complete control of HBV DNA. And that was a Nigerian patient with probably HBeAg serostatus, like an inactive carrier. So the remaining question for HIV/HBV co-infection, does switching to an INSTI-containing ART regimen induce higher cellular clearance rates? And that would be quite useful because I've told you about the HBVQ and all the research around the new drugs, but we are quite far of having that kind of drug. So we definitely need to find new treatment regimen that might trigger functional cure without using those drugs which will come in the future. So there is a necessity to collate case series, and there is probably a need for designing a study with exposure, non-exposure to INSTI. So it could be evaluated in our cohort, but also in other well-defined cohort, in order for us to gather a certain amount of cases and to reach a significance. So that's a call for collaboration if you think that you could be interested in that. So the take-home message to finish, just to remind you of the new estimates of HIV/HBV co-infection, prevalence 6.1%, and to my view, and it can be debated now, there are 4 main challenges in 2020. Evaluating the efficacy of novel biomarkers of treatment efficacy in the context of HIV, and preparing the field for the use of the innovative drugs for functional cure. People living with HIV and hepatitis B should not be left behind. So we have to wake up and not let the others evaluate the treatments instead of us. And the treatment simplification, is it time to rethink treatment paradigm in HIV/HBV co-infection? And finally, the impact of INSTI. Would it be the new drug of choice with regard to HBV clearance in the context of HIV/HBV co-infection? Thank you.
Thank you so much, Karine, for this outstanding and provocative talk. Regarding the study from Côte d'Ivoire, I think you mentioned that only 2% of those who were on lamivudine, they were co-infected, HIV/HBV co-infected patients on lamivudine with low HBV viral loads, so less than 10 to the 5. The rate of emerging resistance to lamivudine was quite low.
0.
Yeah. So my question is, if you have a patient that have full suppression of hepatitis B DNA, I mean less than whatever you cut off, 80 or 20, what is the risk of developing resistance if you switch to a regimen, for example, dolutegravir plus 3TC?
Well, we don't know so far. In this study done in Côte d'Ivoire, why we did this study in Côte d'Ivoire was that because we had the 2 kind of patients on TDF, patients on lamivudine, and we had the follow-up for 36 months. And the patients on lamivudine, about 3/4 of them had HBV DNA under 100,000 copies. Units, and 1/4 was above. So in the 3/4 who were under 100,000 units, we had no emergence of resistance to lamivudine, and we had 2 cases of resistance to lamivudine in the patients over 100,000 units. So regarding your questions, I can't really answer, because those patients were on 3 drugs. Okay, they were not on 2 drugs, they were on 3 drugs. So I think that there are 2 issues. First, could we take the risk of initiating 2D therapy in patients with that kind of profile? Low HBV DNA, HBeAg antigen, I don't know. Can we do the switching strategy to a DR in patients who have been controlled for years and years and years and are HBeAg antigen negative? I don't know either, but that's really the question. And I think that switching, more than initiating, switching could probably be quite interesting.
Okay, thank you so much.
Thank you very much for the excellent talk. My question is about the potential role of the dosification of 3TC in HIV in infected patients. Maybe the 300 milligrams could prevent some development of resistance compared to non-HIV infected patients. Do you think the different dosification has a role in preventing the development of resistance?
So you mean, sorry, I do not get your point. I'm sorry, because I'm a little bit sick, so my ears are not very good. So you mean that...
The different dosage with 3TC in patients
okay.
with HIV?
300, well, the 300 milligram, that's what we use. Yeah. So you mean that doubling the dosing?
The dose.
Oh, I don't know. No, sorry.
No. Yeah, the impact of using 300 milligrams versus 150 in the development of resistance.
300 versus 150, you mean? But in co-infected patients, we use 300. We do not use 150. Yeah. So you mean that using 350 in co-infected, that's why we do not have resistance? Okay.
150 in
non-infected
patients.
Probably, I think it might probably work. It's probably because with such a dosage, we are higher than the C50. But I have no clear answer, really. That's a tough question. I do not have any very specific answer to that.
Okay. Any other question from the audience there?
Hello, I'm Robert from Guadalajara. I had a question regarding when you talk about taking out some tenofovir regimens. Do you think that since we saw from some trials like that you mentioned, it's postulated that it is because an exhausted immune system gets time to recover and then take a more strong response against HBV. So maybe switching to an INSTI regimen is not just switching to an integrase inhibitor, but taking out the drug, the tenofovir, that permits the better immune system to respond and fight against the virus.
Yeah, exactly. So I think that there are 2 issues in that. Either when from the FINI trial, and this paper published by Rinker is not from the FINI trial, but it's another case series of 15 patients where they have looked at the functional T cell restoration after TDF interruptions. And I think that's a very good explanation of why when we stop TDF in monoinfection, we trigger functional T-cell restoration, and that's why the patients can get rid of HBe antigen and finally HBs antigen. So there are two issues in co-infected patients. If we stop TDF, and on top of that, we initiate INSTI with a higher restoration or more rapid restoration of immune system, then it might have a double effect on the immune system of co-infected patients, and it could probably be a good strategy. When we introduce INSTI and we keep TDF or TAF, it might be more an issue with iris, than just functional T-cell restoration. But if we use both, like using INSTI without TDF or TAF, then we might trigger the T-cell restoration and a kind of iris, and then reach HBs and HBe and HBs clearance. And of course, it cannot be applied to all patients. I think that the patients with a low nadir or patients with CD4 T cells under 500 could not be eligible to that kind of strategy. But patients with a high nadir, more than 500 CD4 cells, and HBe, Ag negative, and viral load suppression for years could be a good target for that strategy.
Thank you.
Cortita, José María.
Very short. As you said, hepatitis B infected patients are at risk for developing hepatocellular carcinoma. I wanted to know your opinion about the huge cohort studies recently published at JAMA and also Internal Medicine showing that aspirin or statins reduce the risk of developing HCC in mono-infected patients. What is your opinion about this?
I don't really know. In the context of HIV, HBV, I haven't seen any data regarding that.
But in mono-infected patients, so the results are quite interesting.
Yeah, so I think that's could be interesting. I just saw the data in mono-infection, and I think that we have to reconsider that kind of treatment in mono-infection. But nothing so far in co-infection.
Thank you, Karine. Thank you.